Hi everyone, in this video I'll be discussing the drug distribution. So in the previous video you would have watched what is absorption. It is nothing but from route of administration to systemic circulation. Now we were taking the example of paracetamol. We studied that it was absorbed, there was first pass metabolism, then it reached the liver. Once it has reached the liver, it has to be distributed everywhere. Now we are going to learn what happens in distribution in this video. Now before I go to that part, there is something called plasma proteins and we have to learn about them. So let us understand the plasma proteins first. So in drug distribution, first of all, we need to understand the concept of plasma proteins. What is the first thing I need to know about that? There are two important plasma proteins. Number one, albumin. Albumin. And one more is called alpha 1 acid glycoprotein. Alpha 1 acid glycoprotein. Usually, the acidic drugs, they bind to albumin. So usually, acidic drugs bind to albumin. Remember A for A. So this was the recently asked question in your exam. And basic drugs, they bind alpha 1 acid glycoprotein. Let me give an acidic drug example, a drug by the name furosemide. Furosemide is a loop diuretic, it's a acidic drug. Another basic drug I just want to give you is the name called lignocaine. It's a local anesthetic and an antiarrhythmic drug. So just keep in mind, the acidic drugs bind albumin, basic drugs bind to alpha 1 acid glycoprotein. I have given an example of furosemide and lignocaine for you. The second important point I need to know about this plasma protein is, remember, first thing, all the drugs will not be able to bind to plasma protein. Okay, there are certain drugs which will bind. Okay, so there is a property called plasma protein binding. Not every drug will have that property. Now the next important thing is there is something called a free drug. Now what do you mean by free drug? A free drug is a drug which is not attached to plasma protein. That's the called free drug. Now this is the plasma protein. What I am writing now is the plasma protein PP. Now when the drug binds to plasma protein, this is the plasma protein, and when it binds, then the drug is called as bound drug. Then the drug is called as bound drug. Now please remember, these are in balance. Now what do you mean by that? If free drugs are more, they become bound. If bound drugs are more, they will release the free drug. So that is the balance. Now this is the free drug. Now free drug is the one which is available for, this is the one which is available for what? This is available for the distribution, D for distribution, M for metabolism, E for excretion. For everything, the drug available is free drug. Now it is the drug which is available for the action also. So what is important in pharmacology is the free drug. Now you take the example in your life. Who is more important, a free friend or a friend who is engaged with someone? Obviously a free friend, same thing here. So what about bound drug? The bound drug is not available for any of this. It is not available for any of this. So only if it releases the free drug, then only it is available. So bound drug is like a temporary storage site. It's like a temporary storage site for the drug. It's a temporary storage site for the drug. It's like your bank where you keep the money. There you keep the money in the bank. Like that, it's a storage site. Usually the bound drug will be longer acting. So if the drug is bound, the drugs are usually, it's not a general rule, usually longer acting, because if you keep your money in the bank, it is not used every day. So nowadays you have that phone pay, Google Pay, you will use it faster. But earlier days when you keep in the bank, you have to go to the bank, draw the money, then do it. So keeping in the bank used to make the money last longer. So similarly, if the drug is bound, It is not available for distribution, metabolism, excretion, or action. So it usually makes the drug longer acting. So we understood the first thing, that is albumin, alpha-1 acetylglycoprotein, then free drug and bound drug differences. So the next thing is there are certain drugs which are highly plasma protein bound drug. Highly plasma protein bound drug. What are the examples for that? Example is warfarin, a drug called tolbutamide, and a drug called diazepam. These are highly plasma protein bound drug. Highly plasma protein bound means, suppose I take the example of diazepam, it is around 90% bound form and 10% free form. So it's around 90% bound. So if I give 100 drugs, 90 drugs are already bound and only 10 are free. Similar to warfarin, tolbutamide, they have the same property. Sir, do all the drugs have this property? No. Only few drugs have this highly plasma protein binding property. Examples are warfarin, tolbutamide, and diazepam. I've given the example of diazepam, 90% bound and 10% free when we give the drug. The next important aspect I need to understand is when the drugs are bound, there is a chance of displacement reactions. There is a chance of displacement reaction. So what do you mean by that? Let me take the example. This is a plasma protein. Yes. Now in that plasma protein, a drug is sitting. W stands for warfarin. Now warfarin is sitting there. And if I give the patient who is on warfarin a drug by the name sulfonamide. Sulfonamides are antimicrobial drugs. They kill the microbes. If I give them, what happens? Sulfonamides will kick the warfarin out. Because they are stronger, they can kick the out and they sit on that. So what happens? The free warfarin level increases. Free warfarin level increases and that will lead to toxicity. And the toxicity of warfarin, which is an anticoagulant, warfarin is an anticoagulant to stop the clot. So what happens if that is more? If the warfarin level is more, the patient will develop bleeding because warfarin will stop the clot. So obviously when the levels are high, the clot is not going to form, bleeding will be the risk factor. The message here is don't combine warfarin and sulfonamides together. That's the message. One more example I will give you. There is an endogenous substance called bilirubin. Now for a newborn, if you are using sulfonamide, it can displace bilirubin. The free bilirubin level increases and it can cross the blood-brain barrier and causing kernicterus. So this is again an example of the displacement reaction. So this is usually seen with certain drugs. So this is an example of drug interactions. Drug interaction. So point to take here is sulfonamide should not be given in the newborn because the bilirubin can be displaced and they may develop kernicterus, also called as jaundice. That's the problem. So that is displacement reaction. The next important is the clinical application of this. Clinical application of this. Why should I study this is a question. Okay, sir, we are studying this, fine, but why should I study this? Now, there are two patients, case 1 and case 2. Now, case 1 patient, he has hypoalbuminemia. His albumin levels are lesser. Now, for this patient, you have to give an acidic drug. The acidic drug is furosemide. You have to give it because he has some edema. You have to give furosemide to this patient. The question here is, will you give the normal dose of this? Will you decrease the dose or increase the dose? Pause the video and answer it. The second case is a patient who has MI. So MI stands for myocardial infarction, and during MI there is a chance of arrhythmias, particularly a arrhythmia originating from the ventricle. We call it as ventricular arrhythmia. For that, we use a drug, and the drug is called lignocaine. It's a basic drug. So, a patient with MI with ventricular arrhythmia, the problem is any inflammatory conditions, they increase the production of alpha 1 acid-glycoprotein. So, patient with inflammatory conditions, the alpha 1 acid-glycoprotein level increases. So, the question here again is, will you give the normal dose of lignocaine in this case, or will you increase the dose or decrease the dose? These are all pharmacokinetic application part. Pause the video and tell me. Yeah. So first patient albumin is less, and we know that when we give furosemide is binding to albumin, binds albumin because it is acidic drug. Now, if I give normal dose, what happens? The albumin levels are less. So albumin levels are less, so furosemide cannot bind more. So what happens? There is increase in free levels, increase in free levels of furosemide. What happens if free levels are more? Action is more. So if action is more, adverse effect is more. So in this patient, will you give normal dose? No. If I give normal dose, the free level of the drug increases, the action is more, adverse effect is more. So what should I do? In this patient, what should I do? So you have to reduce the dose and give it. Reduce the dose of furosemide. So very, very good application. We understood now. Case 2 patient, we have to give lignocaine, and I told you in inflammatory condition, the alpha 1 acid glycoprotein increases. So when I give normal dose, what happens? There are more protein, so there is increase in bound form and there is decrease in free form. So what happens now? If the free form is less, will the drug be able to work normally? No, it will work lesser. So in this case, what to do? What to do is to increase the dose a bit. Increase the dose of lignocaine. So even the lignocaine binds to the alpha 1 acid glycoprotein, the free form can be elevated by increasing the dose of lignocaine. So this is the application what we learned from the plasma protein binding. I have given the case example, case 1 and case 2. So let me summarize the points here. So we have the plasma proteins, albumin binds acidic drug, alpha 1 acid glycoprotein basic drugs. Second point is free drug is the one available for DME and action. Then there are highly plasma protein bound drug, very few, 90% bound and 10% free, or 99% bound, 1% free. Not every drug. Fourth, there is a chance of displacement reaction. A stronger drug can displace a weaker drug, sulfonamide, warfarin, sulfonamide, bilirubin. And the fifth one is clinical application. I have told you what we do in hypoalbuminemia and what we do it in inflammatory conditions. So we are discussing the drug distribution. In that we discussed the importance of plasma protein binding and what is the importance and clinical application of plasma protein binding. So once we understand that in drug distribution, we need to understand a concept by the name volume of distribution. So there is something called volume of distribution. And we write this as the VD, volume of distribution, as this. Now once we give the drug enters the circulation and it gets distributed. Now what do you mean by this volume of distribution? To understand that, we will have to understand a bit of physiology. Now if I take a 70 kg man, you know that 60% of the person is made up of water. That means around 42 liters. In that 42 liters, you know that the intracellular fluid is around the 28 liters and the extracellular fluid is around 14 liters. So it is around 28 liters and ECF is around 14 liters. Now in ECF, we have the plasma. The plasma is around 3 liters and the interstitial fluid is around 10.5 liters and the transcellular fluid is around 0.5 liters. So you have learned that in physiology already. So this is the distribution. This is the distribution of the fluid in our body, that is water. This is the water. Now when we give the drug gets distributed everywhere. To understand the distribution, I need to give another basic concept. So take an example, there is a tank here. So there is a tank here. This is the tank, and the tank is, or you will take an example of a small jar. So it's a jar filled with water. Let us tell the water is around 5 liters. A jar with 5 liters of water. And for this jar, we added 500 mg of a drug. We gave 500 mg of the drug and it was added. So when we add that 500 mg of certain drug, it will dissolve in that and it is uniformly distributed. Now you take the same example. This jar has the blood vessel. So this 5 liter has plasma. Now, if I want to calculate the plasma concentration, PC stands for the plasma concentration. So how do we calculate this plasma concentration is how much is the drug we give 500 milligram and how much is the plasma present is 5 liter. That means every liter of plasma contains how much? It is 100 milligram per liter. So plasma concentration is expressed like this. It is milligram per liter. So if you take the example of this jar, that means around 5 liter. If I give 500 milligram of the drug and it is equally distributed, so in every liter, how much you will find? 100 milligram. So if I take that jar as plasma or a blood vessel, you will get this concentration. But this is not ideal situation. When I give the drug will not stay only in the blood vessel, it has to get distributed. Now, let us imagine that it is not getting distributed, it is staying only in the blood vessel. That means if I calculate the volume of distribution, it is given by the formula dose given or dose administered. It is the dose administered divided by the plasma concentration. So let me substitute. How much did we give? 500 mg. What is the plasma concentration? It's around 100 milligram per liter. Now you calculate. So milligram cancels and it is around 5 liters. So distribution is nothing but you only got the idea now. Distribution is a volume in which the drug is uniformly distributed. Uniformly distributed means it is distributed at the level of 100 milligram per liter. And how much volume it is distributed? It is distributed around 5 liters. That is the meaning of volume of distribution. I'll repeat again, if I give the drug to the person and if it distributed in a fluid or a volume, that how much volume is required to accommodate the drug at this level, that is 100 milligram per liter everywhere. That is the volume of distribution in simple words. Okay. But this, what we understood, in the real life situation, that will not happen. The drug has to go out. It has to get distributed everywhere, not only staying in the plasma. Let me take the example here. This is again the same blood vessel I am writing here. This is the same blood vessel here. Right. Now when I give the drug to the person, drug will not stay in the blood vessel. It has to go out. So this is the brain. This is the brain. Then this is the liver. And this is the kidney. So when we give the drugs will move towards this because you know that more the blood flow, more the absorption. So more the blood flow, they will get the more drug. So these organs will get more. The least blood flow areas you all know. The skeletal muscle. The skeletal muscle. So here the blood flows lesser, but still lesser blood flow you all know is for adipose tissue. So here the drug moves slowly. So they will move to these places. Now this moment is what we mean by distribution of the drug. Now let me take the same example. How much I give? 500 mg, correct? So when I give 500 mg to the person, it enters the blood vessel. Now in that 500 mg, 100 milligram went into the brain. Another 100 milligram went into the liver. 50 milligram went into the kidney and 25 to the skeletal muscle and another 25 for adipose tissue. So this much got distributed as soon as I give that IV. Now how much is going out is 100, 200, 250, 275, 300. So how much I gave is 500. How much went out of the blood vessel is 300. So how much is remaining now in the plasma? It is 200 milligram. And how much plasma I told you? It is just for calculation. It's we are taking 5 liters. Now can you tell me what is the plasma concentration now? How much is the plasma concentration? Now plasma concentration is what? What is remaining is 200 milligram. And how much liter of plasma is 5 liter. So what is the plasma concentration now? It is around, yes, correct, 5 fours are 40 milligram per liter. This is the plasma concentration. Now the plasma concentration has decreased now. Why? Because the drug has moved out, that is distributed to other tissues. Now if I tell you the volume of distribution, it is nothing but given by the dose administered. The dose administered divided by plasma concentration. Now in this example, again the dose administered is same 500 mg. And what is the plasma concentration is 40 milligram per liter as per this. Now can you tell me what is the volume of distribution? 0 gets cancelled. It's around 12.5 liters. So volume of distribution is around 12.5 liters. It's around 12.5 liters. Now what did I understand from this? What I understand from this, if the drug stays in the blood vessel, the volume of distribution is less. You take the example here. So I was telling you, the drug doesn't go out. It stays in the blood vessel, and you know that blood volume is 5 liter, so it will be distributed only there. But if the drug is going out, what happens to the volume of distribution? It increases. Now please keep this in your mind. Volume of distribution is expressed in liters. It is expressed in liters. Many a times they may give like this. Volume of distribution is 10 liter per kg. If they have given like this and they have given the patient kg is 70 kg, then what is the volume of distribution? It is around 10 into 70, that is a kg. So it is around 700 liters. So this is how you have to convert when you are doing the calculation. 700 will be the volume of distribution. Okay, sir, we understood that. Fine. Now the next important thing is, let me take one more example here. Suppose a drug we gave is, the dose is 500 milligram. The dose we gave is 500 milligram and the plasma concentration of the drug is 5 milligram per liter. So what is the volume of this drug which is given 500 milligram and plasma concentration is 5 milligram? It is around 100 liters. Now tell me, do we have 100 liters of fluid in our body? So much? No. So this 100 is just a theoretical volume or a hypothetical volume. It's not real. Since it's not real, this volume of distribution is also called as apparent volume of distribution, or we write it in short AVD. So it is a hypothetical volume because in our body we don't have a single compartment. We have multiple compartments. We have blood vessel, we have the heart, we have the liver. All these are multiple compartments. So if we consider everything as a single compartment and we want the drug to be with the equal plasma concentration everywhere, if you want equal plasma concentration everywhere, how much volume is required? That is called apparent volume of distribution. So it's just to give an idea. So here the volume of distribution is 100 liters. Now you all know a drug by the name chloroquine. Chloroquine has a volume of distribution of around 13,000 liters. So chloroquine has a volume of distribution of 13,000 liters. Then what do you mean by that? The meaning is simple. The drug is not staying in the plasma. It is staying outside the blood vessel. That means if the volume of distribution values are more and more, that means the drug is going out. It is not staying in the blood vessel. So let us understand what are the parameters which keeps the drug inside and what are the parameters which keeps the drug outside the blood vessel, or in simple words, what makes a drug property low volume of distribution and high volume distribution. Let us understand that. Yeah. So let me write the blood vessel here. This is the blood vessel. Now I will give the option for you. A drug which is lipid soluble, also called as non-ionized. A drug is water soluble, also called as ionized. A drug is small in size. A drug is big in size. A drug is free. A drug is plasma protein bound drug. Now in these drugs, you pause the video and tell me who can easily go out of the blood vessel. Who can easily go out of the blood vessel? Obviously, the lipid soluble drugs can easily go out. So, lipid soluble, also called as non ionized. Who cannot easily go out? Water soluble. Who can easily go out is the small size or the less molecular weight, and then the free drug. So, you can remember it as small size or low molecular weight. They can easily go out. Now, who cannot go out is the big size because it's bigger in size and plasma protein bound drug. So, the properties of the drug which makes the drug to go out, they are called as high VD, high volume of distribution drug. So, what properties make it high VD are lipid soluble, small size, free drug, and one more property which makes it high VD is if they are more bind to tissue protein, not plasma protein, tissue protein bound drugs. So tissue proteins are present outside the blood vessel. That means they have high VD. Now what makes the drug property low VD? So you know this option already, it is there. If they are water soluble or ionized, if they are large size or large molecular weight, or they are plasma protein binding, these make the drug low VD. Okay, fine. Sir, you are telling all these things, fine, we understood, fine, but why are we studying this? What is the importance of this? The importance of this is suppose you want to design a drug in a pregnant woman. We know that a pregnant woman, when we give the drug, it will go to the placenta, from there to the fetus, and fetus may also get affected. We don't want that. Suppose you want to design a drug to a pregnant woman, will you design a drug with low VD or high VD? Take a guess. Obviously, low VD. Example of a drug which has this property, which is water soluble and big in size, the name is called heparin. The name is called heparin, and it is the anticoagulant of choice in pregnancy. Anticoagulant of choice in pregnancy. Yes, sir. Sir, why heparin is the anticoagulant of choice in pregnancy? Because it's big in size, water soluble, it will not cross the placenta, it will not go to the fetus. So, no problem. Another important thing is, sir, if it is highly plasma protein bound drug, it has low volume of distribution. So, will this property help in pregnant women? Yes. If it is highly plasma protein bound, the drugs are less free, so they don't cross the placenta. So, example I will give again an example by the drug propyl tyrosine. The name is propyl tyrosine. Now, this is used in managing first trimester hyperthyroidism. First trimester hyperthyroidism, the name is called propyl tyrosine. There we use it. So the reason is it is not going to cross easily, that is if it is highly plasma protein bound. Now, another important thing we need to understand why we are learning this. I take an example of poisoning. I will give two options for you. There is a patient coming with drug poisoning and the drug has low volume of distribution. Another drug poisoning, the drug has large volume of distribution or high volume of distribution. Tell me, which poison will you do dialysis? Take a guess. Take a guess. Now, dialysis is not useful in this situation where dialysis not useful in if a drug is having high VD or a drug is highly plasma protein bound? The reason is simple. If the drug is staying outside the blood vessel, the meaning is if you do dialysis, there is no use. If the drug is present in the blood vessel, it will go to the dialyzing machine, get dialyzed, and come back. But if the drug is outside the blood vessel, even if you're doing dialysis, you are wasting the time. That's it. It's very difficult to remove them. And one more, in low volume of distribution also, if the drugs are highly plasma protein bound, they cannot also be removed. So one of the exception in low VT is if the drugs are highly plasma protein bound. Why? Because plasma proteins are not removed by dialysis. That's the reason. So dialysis is not useful in these two situations. Now, because of this, there are certain poison where you should not do dialysis. I will give them. So the mnemonic is better care avoid. So in these poisons, don't do dialysis. Avoid. So B for benzodiazepine. Example is diazepam. Can you tell me why diazepam? Because I just told you diazepam is highly plus protein bound. C for chloroquine. Why chloroquine? Can you give me the answer? Yes, you are right. Because it has highest volume of distribution, 13,000 liter. Then amphetamine. Then a drug called verapamil. Then OP compounds, organophosphate, OP for organophosphate and opioids, and I for imipramine, and D for digoxin. So these drugs, you should not do dialysis. The reason for first I told you, these are highly plasma protein bound. So there is no use. The reason for all the less, these are high VD drugs. So this is the reason why I'm studying this volume of distribution, all those things. Okay, so that's the reason why we are studying this problem. Volume of distribution, we understood this point. Sir, why did you started with physiology is a question. The physiology why I require is, suppose the volume of distribution they have written for a drug is 3 liter. What do you understand by that? It is staying in the plasma. If the volume of distribution is 5 liter, that means you know the blood volume is 5 liters, so it is staying in the blood vessel only. If the volume of distribution is more and more value, that means it is going out of the blood vessel. If it is around 10 liters, 20 liters, 30 liters, that means it is not staying inside the blood vessel, it is going out. That's the meaning why I started my classes telling the normal physiology and normal water distribution in our body. So we understood the concept here. One more concept I just want to tell you here is about the chloroquine. Now, chloroquine is a drug used to treat malaria. It is used to treat malaria. And chloroquine has a volume of distribution of around 1000, not 1000, 13,000 liter. That is the volume of distribution. Very high. Now, when we use chloroquine, this is the blood vessel. This is the blood vessel. When we use chloroquine, suppose if I am giving 100 milligram of chloroquine, now it has to work in the RBC and kill the parasite. So this is the place where the malaria parasite is present. It has to work there. But if I give 100 milligram, all the 100 will go into the outside. If I give 200, all the 200 will go. If I give 300, all the 300 will go. If I give 400, all the 400 will go. If I give 500, all the 500 will go. So at one point, even the tissues outside will get saturated. They get saturated. Now once they get saturated, they don't allow more entry. If I give 600 milligram, then it will stay and kill the protozoa. That is a malaria parasite. So that's the reason when we use chloroquine, initial day we give the dose called 600 milligram, and that dose is called loading dose. So why did we give loading dose? The loading dose is given depending on volume of distribution. So the point to understand here is loading dose depends on volume of distribution. So that's the reason on day 1 of treating malaria, we gave 600 milligram. After 8 hours, we have to give 300 milligram. What is the 300 milligram? The 300 milligram is what we mean by maintenance dose. It is called as the maintenance dose. And please remember, it depends on the clearance. CL stands for clearance of the drug. So both of them have been asked as a question for you. Volume of distribution and clearance. So loading dose depends on VD and maintenance dose depends on clearance. So that is the application why this volume of distribution and all these things are learned. Okay, so I have to give a formula for you. If you know the loading dose right now, loading dose is given by the formula. Target plasma concentration, how much you want to achieve the plasma concentration, PC, into volume of distribution divided by F. F stands for viability. I told you if they have given 60%, the F should be 0.6. If they are given 100%, it should be 1. If they are not given any viability, then don't use the letter F at all. So that is the calculation of loading dose. Okay, so that is about understanding the volume of distribution. Okay, so you understood why it is called apparent volume of distribution, because it's a hypothetical volume and we don't really have that much of volume. It is just a volume to equally accommodate the same plasma concentration everywhere in the body. That is the meaning of volume of distribution, that is called apparent volume of distribution. Now when the drug has to distribute, there are certain barriers for that. So we call them as barriers of distribution. Now, certain places the drug will not enter. Let me take an example of a drug called levodopa. Now, we use levodopa in the treatment of a disease called Parkinson's disease. Now, the problem in Parkinson's disease is dopamine is less. We could have given dopamine only, but dopamine is not allowed in a barrier called blood-brain barrier. So the enzymes in the blood-brain barrier will metabolize dopamine and it cannot enter. So if I want to treat Parkinson's disease patient, I cannot use dopamine because it will not enter the brain. The enzymes in the blood-brain barrier will metabolize it. So that's the reason I give a drug called prodrug, and that is called levodopa, which enters the brain. And after entering, it becomes dopamine. We'll learn that later. So that is the importance of blood-brain barrier, because the nature has given this to avoid a toxic substance from entering the brain. Now another important aspect is brain also has a efflux pump called P-glycoprotein. So whenever some drug enters, it will throw it out. So it is also for protection. That is also for protection. Now many a times this blood-brain barrier may be breached if there is inflammation. If there is meningitis or inflammation, this barrier may not be intact, and certain drugs can penetrate during inflammation. So that is about the blood-brain barrier. So what we are discussing now is about blood-brain barrier, and one more barrier is a barrier called the placental barrier. Again, the placental barrier is not efficient like the blood-brain barrier. It's not so much efficient. It also has the P-glycoprotein to protect, and also there are enzymes to protect, so the drugs will not enter. Again, the question is, if you want to choose a drug for a pregnant woman, what you will choose? It should be big size. Pregnant woman, if you want to choose, what is the property? It should be big size, it should be water soluble, and it should be ionized. So these are the properties ideally we tell, but we don't get ideal drugs. So if you become a scientist, you want to design a drug for pregnant women and we don't want the fetus to get affected, design a drug which is big in size, water soluble, ionized. Now you know that ethanol, lithium, they are water soluble, but the problem is, even though they are water soluble, they are very small in size and they can enter the placenta. So that's the reason it's very important this property should be there. So ethanol, lithium, even though they are water soluble, They are small in size, they can enter the placenta and they can cause telangiectasis. So there are two important barriers for distribution. One is the blood-brain barrier and one more is placental barrier. Okay, so once we understood the distribution, there is one more concept called redistribution. So there is a concept called redistribution. Now, what do you mean by that? What do you mean by that? Let me tell you this concept. There is a drug called thiopentone sodium. Now, thiopentone is an inducing agent in anesthesia. What do you mean by inducing agent? That is the agent which is used to start anesthesia, inducing agent. Now, this thiopentone sodium is used as inducing agent in anesthesia. In anesthesia. Now, what is the specialty of this drug? This drug is ultra short acting, very, very short acting. So, it will work for only 10 minutes, ultra short acting. And the drug is highly lipid soluble. Highly lipid soluble. Okay. So, this is the pharmacokinetic specialty of that. Now, what happens here? Now, when we give the thiopentone, so this is the hand, we give thiopentone intravenous. So, when we give it into the vein, from the vein it goes to the heart. So, from the heart it gets distributed to the brain. So, when the drug reaches the brain, we tell the patient, when we give thiopentone, we tell the patient to count 10, 9, 8, 7, 6. Patient will go for unconsciousness, patient will be anesthesia. So, the drug will have fast onset of action. Now, why did the drug had fast onset? Because it can enter the brain so easily. Why it will enter the brain so easily? Because the brain can be entered because the drug is highly lipid soluble. And because of this property, it is having fast onset, it enters the brain immediately. Now, when we have given the anesthesia to the patient, he is in anesthesia. After 10 minutes, again the patient will come back. Patient will again become conscious. Why? Because the drug has undergone redistribution, and because of redistribution the drug is working only for 10 minutes in the brain, and again the patient is becoming conscious. So because of the phenomenon redistribution, the drug is ultra short acting. The drug is ultra short acting in the brain, so the patient is again conscious. That's the reason why we use this for only starting. So we start the anesthesia and maintain with giving inhaled drugs. We maintain it by giving inhalation drugs. So this is only ultra shorting. Now, what do you mean by redistribution actually? You will understand now. Now, I told you in the beginning of distribution, when we give the drug, this is the blood vessel, the drugs will enter the brain, they will enter the liver, they will enter the kidney because they have high blood flow, but they will enter very slowly into the skeletal muscle, still very, very slow into the adipose tissue. So when we give the drug thiopentone, we know that thiopentone is highly lipid soluble. It enters the brain immediately. It will enter the liver, it will enter the kidney, but it will enter this skeletal muscle very slowly, still very, very, very slowly to the adipose tissue. Right. Now it has gone everywhere. What happens to the level of thiopentone now? It is decreased in the blood vessel. So when it is decreased in the blood vessel, immediately it will come back from the brain again into the circulation. So the drug has entered, it was there for 10 minutes, and when it was distributed everywhere, again it got redistributed back into the blood vessel. And because of this phenomenon, the drug is very short acting in the brain. It is very short acting in the brain, so it will come out. Why it will come inside and come outside so easily? Because of lipid solubility. It can easily go, easily come out, and that's why the patient will become conscious within 10 minutes. But when it enters the adipose tissue, the drug will not come out of the adipose tissue. It can remain there for 9 hours because the blood flow is less and it is bound to the proteins there, and very slowly it will come out. So it will stay there for 9 hours, but it will stay for 10 minutes only in the brain. and this phenomenon is called redistribution phenomenon. So first thing, it got distributed to the high blood flow area, then very slowly to the low blood flow area, and there was less in the blood vessel. So suddenly it came back to the blood vessel, and the drug action terminated in the brain. So this phenomenon is called redistribution phenomenon. It is usually shown with thiopentone and also in general anesthetics. So please remember why thiopentone is ultra short technique. They ask in the exam, it is because of redistribution phenomenon. If they ask in the exam why the drug has fast onset of action in the brain or used as induction agent, because it is highly lipid soluble. This is the answer for it. Now, if you want to plot that in the graph, same thing if you want to plot that in the graph here. So this is the drug plasma concentration. This is the time. So when we give it IV, immediately it will be in the intravenous, then it will fall down. So this is for intravenous. Then it will rise in the brain and fall down. So this is the 10 minutes activity. Then it will rise in the muscle. This is in the muscle. But it will be staying very, very long in the adipose tissue. So the graph for adipose tissue is very, very long. So this is the redistribution graph. It can be asked in your future exams. This is the redistribution graph. Okay, why it is taking so much long time adipose tissue? Because I told you, low blood flow, it takes time. Why it takes long to go out? Again, the low blood flow, it will not go easily. You can see the brain, it has peaked and it has fallen down. And this phenomenon is called redistribution phenomenon. The graph is called redistribution graph. Right, so that is about the redistribution part. So let me conclude this video. So we are discussing the drug distribution. So once the drug is absorbed, it has to be distributed. Now when it has to get distributed, there are two concepts you need to understand plasma protein. Acidic drug bind to albumin, basic drugs bind to alpha-1 acid drug protein. Now the free drug is the one which is available for everything. Bound drug is a temporary storage site. Then there are chances of displacement reaction, and there are certain drugs which are highly plasma protein bound. Then there is something called volume of distribution. It will give an idea whether the drug is present in the blood vessel or outside. Low VD means it is present in the blood vessel, for example, less than 5 liters. What properties make it low volume of distribution? Number one, if it is water soluble, big size, and if it is highly plasma protein bound. If it has high volume of distribution, the advantage, what are the properties that makes it high volume distribution is if it is small size, if it is free drug, if it is bind to tissue protein, and if it is lipid soluble and non-ionized, that will make it. Then we discussed what is the formula for volume of distribution. It is dose administered divided by plasma concentration. Now the volume of distribution is not real. It is an apparent, that's why it is called apparent volume of distribution. Then we understood the application, clinical application for that. And there are barriers for distribution, blood-brain barrier and placental barrier. Then we understood loading dose depends on VD and maintenance dose depends on clearance. And we took the example of chloroquine. At the end, I discussed redistribution. Thiopentone example was taken. It has a fast onset because it is highly lipid soluble, but it is ultra short acting in the brain because of redistribution phenomenon. That is about thiopentone. So that is about drug distribution. Thank you all.